Hello, everyone. Welcome to the Duke Center of Excellence in Manual and Manipulative Therapy Shop Talk. I am Dr. Damian Keter, and today I have the honor and privilege of having Dr. John Mayer with me to discuss his recent publication in Physical Therapy Journal entitled The Influence of Active, Passive, and Manual Therapy Interventions on Escalation of Healthcare Events After Physical Therapy Care in Veterans with Low Back Pain. So before we start, I do have to say that our opinions today are our own. They do not represent those of the United States government, the Department of Veteran Affairs, or any of our other affiliations. So now that we got the formalities out of the way, John, thank you for joining us today. Could you tell us a little bit about yourself, what your current roles are in your background?
Sure. Well, first of all, thank you, Damian, for having me. I appreciate this opportunity, and the whole team is grateful that you selected our work. I'd also like to thank the DoD for funding this grant. The title of the grant is Resolving the Burden of Low Back Pain in Military Service Members and Veterans, or otherwise known as the Resolve Trial. And I'd like to thank the PIs on this grant, which is Sean Faroki and Chris Sturth, as well as the site PIs at the two VA centers that formulated the data for this project. That's Jason Highsmith and Jason Makos. Oh, most importantly, the veterans that serve us and protect us. This is really what it's all about. So we really need to keep reminded of that, how important this type of work actually is, so we can help them give back a little bit to them. So about me, I'm an investigator on this grant, and my main role has been assisting with the activities related to the veterans. For the most part, helping with Jason Highsmith at the Tampa VA, but across the VA setting. So I've been with that. My current role is scientific officer of the Burt Mooney Research Foundation, otherwise known as U.S. Spine and Sport Foundation. I'm a licensed chiropractor. I went to school at National College of Chiropractic, and I also have a PhD in exercise science from Syracuse University. That PhD and my subsequent work in the research aspect has been on therapeutic exercise for managing spinal pain disorders, particularly those people and populations that are at high risk for back pain or injury. So this is a good fit for me. I have been across the board with clinical work and research and educational ventures in interdisciplinary interprofessional settings since the beginning of my career. So I enjoy all three. My current work includes all three as well. So happy to be here.
Yeah, that's excellent. You're definitely well versed in all the topics that we're going to discuss today. So thank you for that. Can you tell me a little bit more about kind of what the backstory is or what led to this specific project that you guys decided to tackle?
Yeah, so as I mentioned, this work is actually part of the umbrella grant of the Resolve trial, and that has both prospective components and retrospective components. One of the aims of that, of the prospective component has three aims. At least one of those can be addressed in part retrospectively. First aim is looking at disability and pain outcomes utilizing evidence-based practices, active-based practices, and particularly psychologically informed physical therapy. The other aim, it looks at medical research utilization and medication use. So we're taking a look at that both in the VA population and the previous work in this grant, retrospective work, they looked at it in the military, active duty military. So a very broad view. Let's take a really close look at this problem in these active military setting and VA veterans as a whole. So this is one aim. This helps answer one of the questions, or research questions within one of the three aims of this trial.
Yeah, excellent. And it's really nice that in this study, you guys utilized your primary outcome that you guys utilized was the downstream effects of, downstream costs, downstream opioid use, things along those lines. And studies are starting to move more towards that and away from the stereotypical pain model, 0 to 10 pain. How does that change things like that? What are your thoughts on using that, or what do you think the big benefit is using that in these large healthcare systems versus the pain model and some of these previous historic models for outcomes?
Well, I'm a big fan of moving away from have a pain-centered anything.
Yeah.
So problematic at the patient level to begin with. We're always talking about pain, 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 pain. You know, rate your pain. As soon as they walk in, rate your pain. So first of all, this type of outcome measure, more of a broad outcome measure, if you will, uh, takes out, gets rid of that a little bit. So let's not, I mean, of course, we're going to keep looking at pain. That's been the tradition. And that's critically important. So I don't want to downplay it too much, but we really need to get out of that. Let's look at function. Let's look at measures such as those we're looking at. What happens after? So short-term pain relief, long-term pain relief, however that's phrased. Well, okay, but let's really take a look at some other measures which are critically important to the patient and the system. So these can help inform directly for the patient care, as well as policies and procedures into the future for people to make decisions.
Yeah.
So we really took a close look at these particular measures, and hopefully, and given the design and retrospective, there are quite a few limitations. However, hopefully this lays a framework to look at this population more prospectively to help guide decision-making in the future.
Absolutely. Absolutely. I agree. And it's definitely a very, meaningful outcome, to across the board. I mean, as we know, is the problem with the opiate epidemic and things along those lines. We know that, the or downstream utilization of pharmaceuticals is a big problem. So yeah, I think it's great. Now, in this study, as with several other recent studies, you considered manual therapy a distinct category, and you didn't include it with the active or the passive treatment groups. Could you kind of elaborate a bit on why you chose to categorize things that way?
Well, pragmatically, I as a clinician, I can't lump it into either one of those. So there's some support in the literature. For example, Dan Rohn published a paper or two on this topic, and it's becoming more of the standard. Wait a minute, this isn't passive. Like when you or other practitioners of manual therapy, I can't even envision how this is purely passive. And if we get a patient that wants to lay on a table, lie on their side, and do a side posture manual therapy, whatever the approach is, and that's all you do, and they lay there like an inanimate object, it doesn't really work. So and there's some manual therapy techniques that you really can't separate the two. For example, McKenzie or mechanical diagnosis and therapy. So patients doing the active component exactly while, if you're doing overpressure, whatever might be in that technique, while you're doing the manual therapy simultaneously. So how would you possibly categorize that as passive? So it just makes sense that it's not considered purely passive. And how is it considered active? Well, not really in the true sense of the word. So it really should be considered separately.
Yeah, absolutely. And I think the results from your study, as well as the results from some of Dan's studies previously, really support that. And the aspect of you guys, when you compared the active care group as the standard, you saw that the group that also received manual therapy had a 30% decrease in the odds of receiving opiate prescriptions in the following year, while those individuals that did get that true passive modalities, e-stim, hot cold pack, those type of things, didn't have that same reduction. So when you categorize them that way, it seems like those results kind of support the idea that they have to be separated into different domains, don't you think?
Yeah, that makes a lot of sense. And I'm a strong proponent of exercise. So it does it for spine care, for general population, prevention across the three types of prevention, treatment, whatever, pretty much no matter what your goal is, exercise is in there as the answer, and specifically for spine care. Of course, there's patient variations and things like that. So with that said, my bias, if you will, towards exercise. So when I saw these results, I'm like, whoa, this is very compelling. And other people have started to see this as well. So we really need to take a closer look at what, why this is occurring. And opioids clearly, opioid use in a subsequent year following a physical therapy intervention is critically important, particularly for this group. So to my knowledge, and I think there's some data on it, this group may use opioids more than the general population. So a 30% reduction is, one, it was statistically significant, but also definitely clinically meaningful. And that needs to be explored further.
Absolutely. And being employed by the Department of Veteran Affairs myself, I could not agree more. I see the results of this study and I see where this could move us moving forward. And I think it's absolutely wonderful. So thank you again for doing this study. So one of the things that was interesting to me is that the individuals who actually received in this study the active interventions alone actually had a shorter PT plan of care as well as less PT visits. However, versus the manual therapy group, the group that also received manual therapy, however, they also had increased healthcare or increased opiate utilization downstream. What are your thoughts on that? This idea that they had shorter plans of care, less visits, but more medication downstream in those active alone group?
Well, first, I'm going to argue that shorter plan of care with fewer visits is not necessarily better, and it's not necessarily evidence-based. So particularly with something like exercise, and some people may argue with me that, oh, you can make long-term changes in behavior with physical activity with a few bouts of exercise, but really, in my opinion, you can't. So a couple, 3, 4, 5 visits of exercise sessions for somebody, and we don't know if this is chronic back pain or acute back pain, but I'm going to venture to guess most of these are chronic cases. So I just can't imagine that with a few, 4 or 5 visits or so with a exercise therapy for somebody with these major problem with back pain, plus the comorbidities that we saw, for example, obesity. Almost half the patients had BMIs above 30. How are you going to make a long-term impact with that? So I'm going to argue that the shorter duration of care was not optimal for those that got active care alone. Now, why did that happen? Did they get a few in office therapeutic exercise sessions and then a home exercise plan? Probably. But I believe that adding the manual therapy was likely involved with improving adherence, which would mean, in my opinion, more visits. So you have a more adherent patient who gets more and we're, as exercise specialists and manual therapists, we're about improving movement patterns quite a bit. Particularly in office, let's improve how you move and then get stronger, more stability, more endurance, all that. But you need more time, which means more visits. So I think that manual therapy, among the other possibilities why manual therapy is effective, is that it helped adherence and foster appropriate movement patterns. So in the skilled aspect of manual therapy, you have more face time with the patient and more time to interact with the patient, discuss perceptions of recovery and expectations of recovery, and importance of adherence, importance of exercise, where a few exercise sessions, and I don't know how it's, I'm sure there's geographic variations in how exercise manual therapy is delivered, particularly in the VA settings. So I don't know in these cases if the patients were, for the exercise component, treated or assisted by a physical therapy assistant or an aide or something, but I'm pretty confident that in the manual therapy setting, they were getting direct interaction with the healthcare provider in particular. So those combinations may help better adherence, which I'm arguing in this case, we're still low on the number of visits, far low. So even with manual therapy, however, we did get a couple, 2.5 more visits on average for those that got manual therapy and combined with exercise. So
Absolutely. And I think you hit an important topic on the nose there. The fact that, the VA being a very large healthcare system, there's a lot of variability in how patients are treated, obviously, within these different PT, physical therapy, and other models as well. And one of the things related to that that I noticed in the results of your study that was really interesting to me and a bit disheartening is when you look at these subgroups, one of the things that stood out is that there were over 1,000, there were 1,200 encounters that used active plus two or more different passive codes. This was more than any of the other subgroups, including active only and the active with manual therapy. As we know that current literature, especially when it comes to low back pain, doesn't really support just this passive management strategies, that's a bit shocking to see that high of a number. So do you have any kind of thoughts on that?
Yeah, so just to reiterate what you said, in terms of number of patients receiving care, this category of active plus two or more passive therapies was the highest utilization compared to exercise alone, and far more than exercise plus manual therapy. Well, on the surface, this analysis provides additional evidence that that increased use of passive modalities is not good. However, we don't know in this particular study if why the therapists were utilizing two or more passive modalities. That would be really interesting in follow-up research. Let's take a closer look at this utilization. Did they perceive that the passive modalities would help with pain relief while going through trying to get better movement, stronger, more stability? Is there some perception of that? Is there some perception that the patients just really enjoy the passive modalities and we don't want to rock the boat? Or is actual benefit? So it's unclear to me, but on the surface, this looks problematic and probably should be one, teased out to find out what the reason is, and two, discourage use of 2+ passive modalities.
Absolutely. Absolutely. Thank you for that. And I know the VA, working here, I know the VA is, currently involved in several educational models trying to improve individuals' understanding of how to manage some of these chronic pain conditions and things like that. So the hope is if it is a problem that isn't related to, there was a rationale behind this passive use, that it's something that changes over time as a lot of these educational models for employees kind of are rolled out. So yeah, but yeah, thank you. Thank you for that. Now we've talked a bit today about how you mentioned earlier with some of the comorbidities in veterans being a little bit different, some of the opioid utilization in veterans being a little bit different. One of the things you mentioned in this paper was this idea that there's a lot of discrepancies between looking at like the VA DoD guidelines, low back pain guidelines, versus those by the American Physical Therapy Association. Do you think this relates to some of these comorbidities and other factors, or do you have any other thoughts related to those differences?
Yeah, so another good question. Why is there difference among clinical practice guidelines in general? So if you, my opinion, and looking at clinical practice guidelines, whether it's a general clinical practice guideline or a physician-based clinical practice guideline, or the guideline from, say, North American Spine Society, which is heavily slanted toward surgeons, or the American Physical Therapy Association, or the chiropractic associations, they all sort of tend to slant towards their perceptions. And there are going to be differences, but some of these differences that we see, and for example, with the American Physical Therapy Association guidelines and the DoD VA guidelines, are hard to explain. For example, particularly, well, some of them are subtle, but the differences with the guideline or recommendation regarding manual therapy is it's hard, it's challenging to interpret. So, for example, the APTA guideline found strong evidence to support manual therapy for both acute and chronic back pain. The current VA guideline, which was reissued or second edition in 2022, found weak evidence to support chronic back pain and insufficient evidence to support recommendations for acute back pain. I can only explain it that they're different different organizations, there are different committee members. When I look closely at the committee members and on these guideline panels between the APTA and the VA, DoD, there's minimal overlap in the members. They have different purposes, different perspectives, and they might be looking at different populations too. So the APTA guidelines are for general populations. These are in the VA, DoD are specific to active duty or veterans. What would be more interesting, which is beyond the scope of our study or my preparation for our discussion, is let's look at the evidence. Let's closely look at the evidence that they evaluated to see if that body of evidence, is it similar, different, or whatever, to see if they're taking the same evidence and interpreting it differently. I love to do that sometime, but that's a heck of a project and I'm not in the plans for a while. So are they interpreting the evidence differently, the same evidence differently? So, and that is common.
Yeah.
So that's common.
Yeah, absolutely. Thank you for that. And I agree. I think this is a good reminder that clinical practice guidelines, although they are very high level evidence, have a degree of subjectivity to it. You know, even when they look at the same articles, which I'm assuming many of them were the same that they included, but I agree, some work comparing those in two of these high level guidelines would be a really nice project to kind of assess why they came up with these difference in opinions. Yeah. So excellent. So
one more thing to add to that.
Yeah.
So it's possible that, but I don't think this happened within the VA and DoD, that they excluded some of the RCTs in the general population and looking more closely at active duty military veterans. So I don't think they did that. However, that's a possibility.
Right. Yeah, that was, like I said, I think that would be a great opportunity for a future study for any of our listeners that want to dive on that one. But so John, with the publication of this work, what do you foresee changing within the VA or within manual therapy practice research? You know, where do you see things going from here?
So this, first of all, some of these findings are very pragmatic, and I'm going to repeat what the paper says about recommendations of the major findings and then give you my opinions on where things could be headed. So clearly the paper has helped create awareness for, hopefully for patients, providers, referring practitioners or referring physicians, and policymakers. We need more standardization. We need to utilize manual therapy more frequently for veterans with low back pain, in combination with exercise, of course. Given the low utilization of manual therapy in this group, this needs to be looked at more closely. We definitely believe that given that only 31% of these patients receive some form of manual therapy, it should be utilized more frequently. Regardless of what we just said before and speculating about why people are getting multiple passive modalities, the education or awareness component, these should be discouraged overall until there's some additional evidence to support utilizing passive modalities for multiple passive modalities for certain types of patients. They generally should just be discouraged. Also, one of the findings that we had in the study is that certain escalation of care events are not necessarily bad. For example, behavioral health interventions, therapeutic exercise interventions, or exercise on general wellness to manage obesity, for example. These aren't necessarily bad. So don't take these findings from this paper and assume all escalation of care. You know, you're just going to get exercise manual therapy for the short duration of time, 5 to 7, 8 visits, and then that's it. So other things need to be done. So not all of this is necessarily bad. One thing we couldn't answer with the study that I think the field needs to move towards in the setting is what we mentioned geographical differences, but what influences the potential barriers towards use of manual therapy in these settings? Is further training needed? What type of providers are are administering manual therapies. And maybe it should be standardized more, and that probably needs more research to look into the barriers a bit more. And given the retrospective nature of this study, prospective studies are needed, particularly those that look at the various comorbidities along with our findings. So I think this study can create awareness, but also has pragmatic applications for the provider.
Excellent. Yeah, absolutely. Definitely some good discussion points there. And I think that, that for anyone who has not read this article, we highly recommend, going on the Physical Therapy Journal website. I believe the preprint is still out. I don't think the official proof has come out. Is that correct, John?
Yes.
Yeah, but sometime soon, I assume the official print will be coming out. And for anyone, like I said, who hasn't read this article, give it a read. I think it's an excellent read. John, any last comments for our listeners?
Yes, thanks again, Damian, for having me here to discuss these findings. And just overall, I'm going to reemphasize our veterans need and deserve our care, particularly evidence-based care. We need to give them the best. We know that management of back pain is not easy, but I strongly encourage everyone to incorporate evidence-based approaches for management of these individuals that are suffering.
Absolutely. Well, thank you for joining us today. Thank you for joining us, everyone. Duke Center of Excellence in Manual and Manipulative Therapies Shop Talk. Until next time, cheers.
Thank you.